Okay, we're going to start with testicular disorders. Now, testicular disorders can be classified into inflammatory disorders, tumors, and a specific entity known as cryptorchidism. And let's start with the cryptorchidism, which is the failure of testicular descent. Usually, cryptorchidism uh, is discovered until the age of 1 year. So before that, usually testicles should be descended. It's most commonly unilateral, so there's only one testy which has not descended into the scrotum. It's usually left in the pelvis or abdomen. And the complications of the cryptorchidism, aka the failure of testicular descent, includes testicular atrophy and infertility, as the testy is stuck in the pelvis. It can get atrophied and it may result in infertility. We have testicular tumor, which is 5 to 6-fold increase in people with cryptorchidism. And there's also an increased risk of tumor if there's a unilateral cryptorchidism. There's increased risk of tumor in the contralateral testy, the one that has descended normally. The normally descended testy also has increased risk for the tumor. And lastly, we have testicular torsion, which is the twisting of the spermatic cord. It's an urologic emergency which needs prompt surgical treatment. So these are basically all about the cryptorchidism. Usually, to fix the cryptorchidism, surgery is performed to descend testy manually. The physicians usually wait up to 18 months to make sure that if they can automatically descend, they will descend up to 18 months. If not, surgical treatment is necessary to avoid those complications. Now, other testicular disorders are inflammatory disorders, including orchitis. This is the inflammation of the testes. The most common causative organism, the virus is mumps. It can be due to the mumps virus. It can be due to the radiation. And there's another one as well. I think tuberculosis can cause the orchitis as well. The second inflammatory condition affecting testes is epididymitis, which is the inflammation of the epididymis. This structure is epididymis. So in this case, the most common causative organisms are the ones that cause sexually transmitted infections, such as Neisseria gonorrhea, chlamydia, and also for children and older male patients, we have E. coli as a causative agent as well. Now, symptoms of epididymitis include sudden, acute, severe testicular pain. It can be swelling as well, with or without redness, and as well severe tenderness on palpation. Now let's get to the testicular tumors, which are very important. Testicular tumors include the most common tumors of the testicle are the germ cell tumors, which is 95% and above, causing the malignant tumors in males. In case of the male germ cell tumors, testicular tumors, all those tumors are malignant, compared to the women's germ cell tumors, which is not always malignant. So germ cell tumors of the testicle is always malignant. Now, the prevalence in age-wise, it's very interesting because it usually happens in the second decade to the fourth decade of life. It can be from 15 years to 40 years, and risk factors most likely is going to be idiopathic, and 10% is associated with cryptorchidism. So 1 out of 10 patients with the testicular cancer had a cryptorchidism as well. Also risk factor, if there's a familial predisposition, a genetic predisposition, that one is a risk factor as well. Okay, let's discuss one by one those testicular germ cell tumors. The most common testicular germ cell tumor is the seminoma. It occurs in about 55% of testicular tumors. 15% have syncytiotrophoblastic tissue, which secretes human chorionic gonadotropin, but it's only in 15% of seminomatous testicular cancer cases. Morphologically, we can see clear cells with cytoplasmic glycogen. Those are like a clear round cells with the white glycogen in the cytoplasm. So this is seminoma. Now, what's important in the testicular tumors that usually never solitary tumor is rare, right? It's usually a combination of several types of tumors. For example, seminoma and the yolk sac tumor together, the embryonal carcinoma with the teratoma, and it's usually intermixed with each other. Now, let's talk about non-seminomatous germ cell tumors. Those include choriocarcinoma. Choriocarcinoma is, compared to other testicular tumors, a bit worse in case of prognosis, because it metastasizes really quickly compared to other testicular tumors. Now, what we can see about this choriocarcinoma is that there's always a cytotrophoblast and trophoblastic tissue inside of this kind of neoplasm, and they secrete human chorionic gonadotropin, HCG, which is highly elevated in case of the choriocarcinoma. In case of the teratoma, there's no marker at all. A teratoma, as you know, is the neoplasm which arises from all three types of germ cell layers, from the endoderm, mesoderm, and ectoderm. It can be either immature or mature, the immature looking or mature, well differentiated and not, for all three embryonal layers, right? It doesn't matter either it's immature or mature, both of them are 100% malignant. So there's no benign teratoma in case of the testicular cancer. And this teratoma can be the cells of the epithelium, neural cells, mesenchymal tissue, and it can also be, for example, bronchial tissue in this teratoma. Now, yolk sac tumor is 100% expresses alpha-fetoprotein. There's a characteristic morphological feature known as Schiller-Duval bodies. And if you look at the microscopical picture of the yolk sac tumor, those Schiller-Duval bodies look exactly like the glomeruli of the kidney. So they look like a primitive glomerular structures, but they have nothing in common with the regular functioning glomeruli, right? They just look, via the eye, you can notice that they look very similar. Now, the fourth type of, and the last one, in case of the testicular cancer, is embryonal carcinoma. In case of the embryonal carcinoma, there's no biomarker for this cancer, but important characteristic is that embryonal carcinoma is hemorrhagic. So this tumor itself is hemorrhagic. Okay. Okay, so we've discussed that. Now let's talk about other testicular disorders. This is normal testicle. You see the pampiniform plexus, epididymis, and testes. And there are layers of the testicular sac. This is called tunica vaginalis. So all three layers together are called tunica vaginalis, right? Now, let's discuss disorders. First is hydrocele, which is accumulation of the fluid inside of the testes. It usually happens if there's a inappropriately aligned tunica vaginalis, which causes some kind of leakage of fluid inside of the testes. So that is the problem with the hydrocele, right? There is accumulation of water inside the testes. Muklo. Okay, So important diagnostic value in case of the hydrocele is the positive transillumination test, which means if the urologist points the torch at the testy, it's going to be with some kind of translucent, right? So there's second condition, which is spermatocele. There's an accumulation of the sperm in the epididymis, which causes the swelling of the epididymis, and it's also positive for the transillumination test with the torch. Now, varicocele is a disorder where the pumpiniform venous plexus, one or several veins, or maybe all of those venous plexus veins, can be dilated. It's a very common condition. It usually affects left testis more than right testis because of the anatomical alignment of this venous drainage from the testis. You see from the right testis, the venous plexus directly drains into the inferior vena cava, which is located lower than the left renal vein, right? In case of the left testicular veins, they drain not directly to IVC, but they drain first um, into the renal vein, in the left renal vein, and then this left renal vein drains into the IVC. So in this case, you can see that this is left renal vein is higher than the IVC and that's why, because of the gravity, usually the problem happens in the left testicle as the blood is getting congested in this veins, causing dilation of the veins and congestion of the blood inside of those veins. So the symptoms, it's sometimes painful. It can create episodic pain. The major complication of the varicocele is that it may cause infertility, and it usually gets ligated. The vein that is affected is usually get ligated with a procedure called varicelectomy. And in case of the testicular tumor, we have the mass on the testicle, depending on what kind of tumor it is. And in both cases, in varicocele and testicular tumor, there's negative transillumination test. So you cannot notice anything with the torch. Okay. Okay, let's talk about the some torsion as well, testicular torsion. So torsion is a condition which is in one of the few urologic emergencies. Torsion is when you see that's the spermatic cord, right? You see spermatic cord in here. So the torsion is when spermatic cord gets twisted and it's some kind of occlusion of the veins that causes the ischemia of the testis. So it's really important to make sure surgical emergency is done quickly. It's usually from the onset of torsion in 6 hours. It is important to make sure it's untwisted as it can cause atrophy of the testicle and ischemia as well. So symptoms of torsion include sudden, acute, severe testicular pain, swelling. It can or it cannot lead to cyanosis, and there's severe tenderness, so it's very painful. It's so painful that it can awake you at night, so it's usually taken care of. But it's important to make sure you go to the doctor so it's an emergency, right? It's in the duration of 6 hours. And usually the cause of the testicular torsion is congenital anomaly of the alignment of the testi, which gives it ability to twist around and be as more mobile than usual, causing the twisting of the spermatic cord. Okay, let's talk about the prostate disorders. We have inflammatory disorders and proliferative disorders, which include benign prostatic hyperplasia and cancer of the prostate. Let's start with the inflammatory disorders. So we have acute bacterial prostatitis, which usually affects old men, ascending infection by E. coli is caused by E. coli in the old men, and in young men it's usually gonococcal or chlamydial, the one that causes sexually transmitted disorders. So in case of so this is acute prostatitis. In case of the chronic prostatitis, it's also caused by ascending urinary tract infection such as E. coli, and chronic bacterial prostatitis, which happens in case of women due to the chronic pelvic pain syndrome. In this case, it's idiopathic. So the prostatitis, the acute prostatitis symptoms include perineal or low back pain discomfort, dysuria, urgency, frequency, nocturia, hesitancy. It can be fever, and also decreased urinary stream is usually for the chronic bacterial prostatitis. So fever, and also there might be chills, the symptoms that can be associated with the bacterial infection. Yeah, palpation is avoided. Okay, yeah, and this is important as well, because if you suspect the patient is experiencing acute bacterial prostatitis, it is best to avoid the palpation of the prostate, because it can lead to seeding of the bacteria, which is accumulated. A lot of bacteria is accumulated in the prostate, which can readily spread via the hematogenous spread in the bloodstream, and there's a risk of sepsis as well, right? Let's talk about prostate disorders, the proliferative ones, which let's start with the benign prostatic hyperplasia. This is we can call it a physiological process, because it usually affects every male who has a regular testicular development without any kind of, I don't know, cryptorchidism, if there wasn't a castration. So with regular functioning testes, people aged from 40 to at around 80 years develop benign prostatic hyperplasia. So prostate can be divided in two parts. One is the central prostate, the tissue of the prostate, and the other part can be called a peripheral part of the prostate. So what is important in case of the benign prostatic hyperplasia is that the tissue that is getting hyperplased is the central area, and the central area of the prostate aligns urethra, right? So if there's a hyperplasia increase in tissue, in cell number, the tissue is going to get increased, and it's going to cause obstruction of the urethra. Okay? So it's usually caused by androgens and DHT. DHT is the most active androgen, dihydrotestosterone, that causes stimulation of the prostate, and subsequently, after a long period of time, like after 50 years, it can cause the prostatic hyperplasia, causing urethral obstruction. Okay, and due to the urethral obstruction, there might be other problems as well associated with it, as the urinary bladder is not getting emptied completely. There might be ascending bacterial infections and other complications as well. Okay, let's talk about the prostate cancer. Now this is the first. This is on the first. Via the ranking is the first cancer by incidence in males, and the second cancer by mortality. So it's aggressive, but at the same time, it's important to understand that prostatic cancer, carcinoma of the prostate, it develops usually in the older patients, like median 60 to 75 years, and many people are affected. And at the dissection, when the person dies, usually from other causes, the pathologist or someone who's dissecting the patient discovers that that patient had prostate cancer as well, right? So it usually not very doesn't spread very quickly. So it's for the older aged people, they don't usually even treat this prostate cancer, right? Okay, it's associated with hyperandrogenism, involves peripheral zone. So to differentiate it from the benign prostatic hyperplasia, it usually affects the peripheral zone, and urethral obstruction is not evident unless the prostate cancer is in the very late stages. Okay? Okay. Moderately differentiated adenocarcinoma, specific markers. Oh, it's adenocarcinoma, not the. Yeah, okay. So, specific marker is, and the only one that can be used is prostate specific antigen. Unfortunately, this is not the best for the diagnostic tool, but diagnostically is not the best marker, as because of the ejaculation of sperm, PCA can increase, and also in case of the benign prostatic hyperplasia, prostate-specific antigen increases. So it's not very specific marker, right? But in case of the treatment, if there's radical prostatectomy, if the prostate has been resected, completely, then it can be used to manage if the PCA levels uh, go high after the resection of the prostate, it can be indicative of the metastasis, and then it's important to make sure we measure PCA. Okay, symptoms of the prostate cancer is usually symptomatic: pelvic pain, invasion of pelvic plexus, weight loss, very late stages, and usually patients come with the complaint of the low back pain, lumbar vertebral metastases. So usually it's so asymptomatic that until the metastasis, patients do not experience any kind of symptoms. And when they already experience metastasis to the vertebral spine, it's usually very late. Yes, and urinary obstruction symptoms, it's when the prostate cancer progressed to a very late stage, so it also invades the central zone of the prostate. But usually in the first stages, it doesn't affect the urine flow. Yes, that's important as well. The genetic predisposition is if there's a mutation of the TMPRSS2 fusion with the ETS, causes that can be predisposed as the prostate cancer. Okay, so this is the treatment of the prostate, benign prostatic hyperplasia. So usually the first line for benign prostatic hyperplasia, it usually causes symptomatic relief, which is alpha-1 blocker. This alpha-1A blocker, it's tamsulosin, mm, which causes some kind of relief. So the prostate is not constricting urethra so hard. So alpha 1A blockers usually relieve urethra from the prostatic hyperplasia. And the other type of drug that can be used is finasteride, which is 5-alpha reductase inhibitor. 5-alpha reductase is the enzyme that converts testosterone to dihydrotestosterone. So if we block 5-alpha reductase, testosterone is not going to get converted to DHT, and DHT is not going to stimulate prostate. Testosterone doesn't have a direct action on the prostate, so it's important for it to be converted to DHT first. Okay, so finasteride is also used for the pattern baldness in males as well. Symptoms of benign prostatic hyperplasia include urgency, frequency, nocturia, hesitancy, decreased urinary stream. So those are all associated with the obstruction of the urine flow of the urethra. Complications include obstruction with inability to urinate, hydronephrosis with postrenal isotemia. Hydronephrosis, as you remember, is the accumulation of the fluid of the fluid in the kidneys. And the postrenal azotemia is when there's the kidney flow is obstructed. Ascending infections such as cystitis, pyelonephritis, due to perfect media, as the urine usually washes away ascending bacteria that tries to crawl up to the urinary bladder or to the kidneys. When there's a problem with the urine flow, it's beneficial for bacteria to crawl better. Okay. Okay. I forgot to mention the symptoms of prostatitis. In urinalysis, we can see white blood cells on urethral swab or in the urine. Due to the bacterial infection, white blood cells will be there. Culture of the urine and prostate secretions. It's to understand which is the causative bacteria for the prostatitis. Negative culture is usually chronic bacterial prostatitis, which was associated with the pelvic inflammatory syndrome in women. And if the culture is positive and there's a chronic prostatitis, it's bacterial prostatitis, which is chronic. Okay. Now what we have in here. Okay, this is this syphilis. Syphilis. Okay. Bladder cancer. Okay, let's get to the bladder now. In case of the bladder, we have cystitis. So cystitis is the inflammation of the bladder. Cystitis can be divided in 3 categories, but there's 2 more conditions that affect bladder. Let's discuss those 3 first. So we have bacterial cystitis, which is caused by ascending bacterial infections, and the most common causative organisms is E. coli. Usually the gender associated with the cystitis, mostly predisposed to cystitis, are women due to shorter urethral anatomy. So the most common causative organism is E. coli. On the second ranking, we have Staphylococcus saprophyticus, and the third one is Proteus. So this is bacterial cystitis associated with the frequency, urgency to urinate, frequent urination, and etc. In case of hemorrhagic cystitis, we have blood in the urine. This is usually a rare complication of the adenoviral infection, and it can also be caused with the cyclophosphamide, which is a anti-cancer medication used in chemotherapy. So, and the third type of cystitis is interstitial cystitis, which is idiopathic, and it usually gets complicated with extensive fibrosis of the wall. Interstitial cystitis has no known cause, but in 50% of cases it can be transient, so it can go to remission in like 50% of patients experiencing this. There's also another condition called malakoplakia, which is the defect in macrophage or degradative lysosomal enzymes. This causes the accumulation of bacteria inside of the macrophages, which causes calcifications, the calcium deposition, and subsequent inflammation of the the urinary bladder. Okay. Okay, this we discussed already. Now let's talk about bladder cancers. So we have 2 types of the bladder cancer. The most common one is transitional cell cancer. Transitional cell is the urothelium. Transitional epithelium is what covers the urinary bladder, the special type of epithelium. So in 95% of cases, neoplasms arise in this epithelium, the transitional one. But in less than 5%, we have squamous cell cancer. Squamous cell cancer is usually associated with the schistosoma hematobium, which is a helminth. It usually is prevalent in the India and tropical areas. Now this is malignant squamous cell transformation, extensive keratinization with keratin pures, and foam flat invasive carcinomas. So it's very rare, caused with schistosoma hematobium. In case of transitional cell cancer, the most common causative, the predisposing factors are smoking, which is in the first place. There's chronic cystitis, and there's aniline dyes, cyclophosphamide use, the anti-cancer medication, and also radiation. Now, we need to make sure that we differentiate the transitional cell cancers, as there are two types of lesions that can lead to cancer. The one is, I do not have a marker, so I could write it down. So the bladder cancer can arise as the papillary cancer, or it can be carcinoma in situ, which can then progress to invasive cancer, right? So in case of the papillary lesions, we have papillae inside of the urinary bladder. And those papillae are characterized that they're divided into four types. One is the papilloma, which is benign. There can be papillary neoplasm with low to malignant potential, and then we have low-grade papillary neoplasm and high-grade papillary neoplasm. High-grade is the worst one, right? Now it's also important that there is a benign papillary growth, which is the part of cystitis, and the papillae inside of in case of papillary cystitis is benign, but it looks exactly like the neoplastic papillae. So we have to differentiate either it's benign or neoplastic. Okay. So morphology, and as I already mentioned, there's also a carcinoma in situ lesion, which can progress to the malignant cancer of the bladder if it invades the inner layers of the bladder as well. If it goes, it might go to the lamina propria, and if it's very extensive neoplasm, it can even reach the muscularis propria layer of the bladder. Yes, so in malignant neoplastic cells from transitional epithelium leading to invasive papillary carcinoma. So it's either papillary carcinoma invasive or carcinoma in situ which progressed to invasive carcinoma. Let's now talk about the symptoms of the bladder cancer. It's usually painless hematuria. We have weight loss, as it is a cancer, and anorexia is a very common sign of the cancer. We have urgency, frequency, and dysuria due to irritation and mess in the bladder, right? There's definitely going to be a mess if there's a cancer. Okay. We're done with the bladder as well, and the last part, which I'm going to talk about, is the urinary tract infections, not sexually transmitted infections or sexually transmitted diseases, aka STD, STI. So let's talk about bacterial infections first. And in the United States, the most common bacterial infection that causes the sexually transmitted disease is gonorrhea, caused by Neisseria gonorrhea species, the gonococci. But in the rest of the world, the most common pathogen is Chlamydia trachomatis. So in case of the United States, we have the most common gonorrhea, and let's start with the gonorrhea now, as the book is based on the United States system. Okay, so Neisseria gonorrhea is a gram-negative it's a gram-negative cocci, No, so it causes infection via ascending route in the genitourinary system, and it causes in males it causes urethritis, which is characterized with the dysuria, pyuria, and purulent discharge. It is important as the pyuria is the pus in the urine, and purulent discharge is pus coming out of the urethra. It can also lead to epididymitis, which is the inflammation of the epididymis, severe acute testicular pain, swelling, redness, tenderness, and also fever. Characteristic of the epididymitis that we discussed earlier. It can also lead to acute bacterial prostatitis, which we discussed before, lower back or perineal pain, with the dysuria, frequency, urgency, fever, and that's all in case of males. So the main is urethritis, and then it can lead to epididymitis and also acute bacterial prostatitis. So now let's talk about the females. In females, the first thing that it causes is the inflammation of the urethra with the same symptoms: dysuria, pyuria, purulent discharge. Gonorrheal infection is mostly asymptomatic in both males and females, but it can be more asymptomatic in females, more commonly asymptomatic in females. It also can lead to cervicitis with the mucopurulent discharge, dyspareunia, which is painful sexual intercourse, and motion tenderness, right? Which means with the motion, it's painful for the woman infected with the gonorrhea. Pelvic inflammatory disease, which is characterized with salpingo-ophtheritis. There's inflammation of salpinges, also known as fallopian tubes. It is characterized with the fever, mucopurulent discharge, a painful sexual intercourse, dyspareunia, motion tenderness, adnexal tenderness. Adnexa is also salpinges, also known as fallopian tubes. And now let's talk about the complications. In case of the females, we have acute bacteremia and sepsis. It's very rare complication though, but usually complication is in females. This is gonococcosemia and tubo-ovarian abscess. In case of the chronic gonorrheal infection, there's fibrosis and adhesions of fallopian tubes, which leads to infertility and also may lead to ectopic pregnancy. Now, complications both in males and females include septic arthritis. 30 to 40% of males and females affected also have chlamydial infections. So it's like if someone has a gonorrhea, there's a 30 to 40% chance that he or she is going to have a chlamydia as well. And it's the same for the chlamydial infection. There's 30 to 40% chance that a patient affected with chlamydial infection might have gonorrheal infection. Now, the complication, if the mother is infected with gonorrhea, there might be complication of the infant. Okay, so the neonatal complications including ophthalmia neonatorum, which is purulent keratoconjunctivitis, and it